Good afternoon, everyone. Today we are going to discuss viral infection. There are a few viral infections of the skin that you should know that are herpes simplex infection, herpes zoster infection, molluscum contagiosum, warts, and varicella or chickenpox. These are the main five important viral infections of the skin that you should know. First of all, we are going to discuss herpes simplex infection. Herpes simplex infection are caused by herpes simplex virus or herpes simplex virus are also called herpes virus hominis. Herpes simplex virus are of two types, type 1 and type 2. Type 1 are classically associated with facial infections and type 2 are associated mainly with genital infections. The infections by herpes simplex virus are acquired by direct contact or with the droplets from infected secretions which enter via skin or mucous membrane, either direct contact or droplets. And latent infection is very common in herpes simplex virus, where the virus reside in the ganglia of sensory nerves innervating the primary infection site. And from this condition of latency, virus may travel along the nerve fiber and it may replicate in the skin and mucous membrane, which causes recurrent disease. And the virus can also be seen in saliva and genital secretions from asymptomatic individuals. And type 1 primary infection, that is the facial infections, occur mainly in infants and young children. And they are usually minimal and often subclinical. Primary infections may, however, rarely produce painful vesicular stomatitis in children. And type 2 infections occur mainly after puberty, and these are mainly transmitted sexually. And herpes simplex virus 2 infection is more commonly symptomatic than herpes simplex virus 1 infection. There is a term called non-primary first episode infection. It is the acquisition of herpes simplex virus at a new site in a patient previously infected at a different site. It is called non-primary first episode infection. If we do pathological examination of the skin that is infected by herpes simplex virus, there are a few characteristic features that we can see. The first one is ballooning degeneration, where cytoplasm of the infected epithelial cells become edematous and swell. It is called ballooning degeneration. There are also intranuclear inclusion bodies, and there are also giant cells containing two or more nuclei. In the clinical features, the primary infection is often subclinical. And when clinical lesions develop, the severity is generally greater than in recurrence. That is, the first time infection is always severe than the recurrent infection. And genital primary disease is more commonly symptomatic than oral. Now, the herpetic gingival stomatitis, it is the most common clinical manifestation of type 1 herpes simplex virus infection. And most cases occur in children between 1 and 5 years. Usually after an incubation period of approximately 5 days, the stomatitis begins with fever, malaise, restlessness, and excessive dribbling of saliva. It is very painful, and the gums are swollen, inflamed, and bleed easily. And the vesicles, which present as white plaques, are present on the tongue, pharynx, palate, buccal mucosa, and buccal mucous membranes. And the plaques develop into ulcers with yellowish pseudomembrane. The regional lymph nodes are enlarged and tender, and after 3 to 5 days, the fever normally subsides and recovery is usually complete in 2 weeks. Now, the herpes genitalis, it is caused by herpes simplex virus type 2. It is usually sexually transmitted, and the ulcers are most frequent in glands, prepuce, and shaft of penis. And these are painful and last for 2 to 3 weeks if these are not treated. In HIV infection, that is in immunocompromised state, However, ulceration may become chronic. It may last longer than 2 to 3 weeks. And in females, similar lesions occur on the external genitalia, mucosa of the vulva, vagina, and cervix. Pain and dysuria are also common. This is the picture you can see. This is herpes simplex virus 2 infection. You can see vesicles. These vesicles later erupt to give appearance of ulceration. In recurrent infections, it differs from primary infections because in the recurrent infection, the vesicles are smaller and they appear in close grouping, and there are usually absence of constitutional symptoms. You can see these are the example of recurrent infection in which there are grouped vesicles over the erythematous space. And the complications of the simplex virus, sometimes infections sometimes are complicated, like eczema or peticum. Eczema or peticum is the appearance of generalized herpes simplex virus infection in patient who is already having eczema over body. There can be headache, meningism, disseminating infection, recurrent herpes simplex infection. There can be erythema multiforme also. Erythema multiforme, I think we have discussed once. It is a type of reaction in which you can see target lesions over the extremities, mainly palms, soles, hands, feet, which later progress to other parts. In the target lesion, there are 3 well-defined areas. Central area, dusky erythema, which is surrounded by pale area, which is again surrounded by erythematous layer. And erythema multiforme can also be seen in drug reactions also. And other complications can be Bell's palsy, recurrent lymphocytic meningitis, and encephalitis. Now the treatment, mild uncomplicated eruptions of herpes simplex virus require no treatment, and use of topical antiseptic agent on the affected skin help to reduce the risk of secondary infection. However, in case of severe infection, we have to give antiviral therapy. In the primary infection, if it is severe, a cyclovir is given intravenous, 5 mg per kg, IV 8 hourly. Or in the moderate to mild infection, we can give acyclovir 400 mg TDS for 7 days, or 200 mg 5 times a day for 7 days. But 400 mg TDS for 7 days is more commonly practiced because it is easy dosing. It is easy to take drug 3 times a day than 5 times a day. And valacyclovir also can be given, but we mostly give acyclovir. And in case of neonatal herpes, we have to give acyclovir 60 mg per kg per day in 3 divided dose for 2 to 3 weeks. In case of recurrent herpes infection, if it's mild, it does not require any treatment. We can give topical antibiotic cream only. Sometimes you can give 5% acyclovir cream also. And if it is problematic, moderate or severe, you can give acyclovir 400 mg TDS for 5 days. In the primary infection, it was 400 mg TDS for 7 days. In recurrent infection, we are giving 400 mg TDS for 5 days. And if the recurrences are frequent, we have to give long-term prophylactic acyclovir at a dose of 200 to 400 mg twice daily for 4 to 6 months. This is for frequent recurrences. In case of genital herpes, the doses of acyclovir is same. 200 mg TDS for 5 days, or 400 mg TDS for 5 days, or 200 mg 5 times a day for 5 days. Other drugs, you can give valcyclovir, famciclovir, And if resistant to acyclovir, it can be postcarnate or pseudoprovir. These other drugs, you don't have to remember the doses, but for acyclovir, you should know the doses also, doses of drug. Now the varicella zoster infection. It is caused by varicella zoster virus. Okay. Herpes simplex virus is different and varicella zoster virus is different. You should not confuse herpes simplex virus with varicella zoster virus. These both varicella zoster and herpes simplex virus belong to herpes group of virus, but these are different. And varicella zoster virus usually affects younger age group, and it is more common in cooler winter and spring months. It is transmitted by droplet infection from the nasopharynx. At first, there is brief viremic stage, and then the virus disseminates into the other organs, which is followed by second viremia coinciding with the onset of rash. That is, during the second viremic phase, there is rash seen in the body. And this infection, varicella infection, is infectious to others from about 2 days before to 5 days after the onset of rash. And varicella confers lasting immunity. If the person is infected once by varicella, he will be immune to varicella. He will be immune to chickenpox, varicella zoster virus infection, but he is not immune to herpes zoster virus. Herpes zoster infection. We'll discuss what is herpes zoster later. The person will not get chickenpox, but may get herpes zoster later. And the incubation period is 14 to 17 days. It ranges from 9 to 23 days. It is preceded by fever and malaise. And then there is scarlantiform or morbilliform erythema, over which papules appear, and the papules rapidly change into tense, clear, unique, locular vesicles. And vesicles then change into pustules, which are surrounded by red areola. And in 2 to 4 days, the dried pus forms over the area, and it separates to leave a shallow pink depression, which heals without scarring. And the vesicles appear in 3 to 5 drops over 2 to 4 days. The vesicles are most numerous on trunk, then on the face and scalp, and on the lips. This distribution is called centripetal distribution. And the rashes of the varicella infection are called pleomorphic because there are different stages of lesions present at the same person. Okay? Sometimes there can be papules, there can be erythema, there can be papules, there can be vesicles, there can be pustules, there can be cusps, all different stages of the lesion at the same time. Vesicles are also common in mucous membranes also. And after about 4 days, there are no new crops of lesions, and the existing vesicles and pustules dry and crust. Now, this is the picture showing varicella, and it is severe, as you can see. There are vesicles over erythematous base. This is also known as dew drop on rose petal. These vesicles, as you can see, it's over erythematous base. It is also known as dew drop on rose petal sign. And the common complications, not common complications, but the rare complications which can occur in the chickenpox are encephalitis, pneumonia, hepatitis, secondary infection over the lesions, septicemia, cutaneous gangrene, which is also called varicella gangrenosa, and thrombocytopenic purpura. And if there is maternal varicella in the first 20 weeks of pregnancy, it can be associated with 2% risk of fetal damage. There can be skin lesion, it can also affect central nervous system, there can be ocular defects, and there can be limb hypoplasia. And if the mother has varicella within 4 days before, 2 days after delivery, the neonate will have no maternal antibody and is at risk of severe varicella infection with mortality up to 30% if there is no treatment. Now the treatment of the varicella. In otherwise healthy children, it requires only symptomatic treatment. No antiviral treatment is required. Only rest, analgesic, and soothing antiseptic applications. If there is secondary bacterial infections, we have to give antibiotics, oral and topical antibiotics. Otherwise, there may be scarring, and antiviral is indicated for varicella in children who are more than 12 years old. Okay? Or adults and children with severe varicella, or if they are immunocompromised, okay? Then only antiviral drug is required. And the treatment should be started as early as possible, preferably within first 1 or 2 days. Okay? Within 40 to 48 hours, the treatment of varicella, that is antiviral drug, should be started. If the infection is severe, we have to give acyclovir 10 mg per kg or 500 mg per meter square 8 hourly IV for 7 to 10 days. In mild to moderate infection, we have to give acyclovir 20 mg per kg per dose, 5 times a day for 7 days. Okay? And if we assume that first patient is of 40 kg, it comes around 800 mg 5 times a day for 7 days. We can also give valacyclovir and famciclovir also. Now the herpes zoster infection, it is also caused by varicella zoster virus. Herpes zoster is also caused by varicella zoster virus, and the incidence of herpes zoster increases with age. And after the primary infection of varicella, chickenpox, varicella zoster virus persists in the nerve ganglion cells, usually sensory ganglion, and the reactivation of these residual latent virus causes herpes zoster. And zoster species are infectious both from virus in the lesion and in some instances from the nasopharynx. Now the clinical features. The first manifestation of zoster is always pain. Right? Pain appears 2 to 3 days before the onset of rashes, and it may be accompanied by fever, headache, and malaise. And after 2 to 3 days of pain, there appears closely grouped red papules, which rapidly become vesicular and then pustular. These group vesicles develop in a continuous or interrupted band in the area of 1, occasionally 2, and rarely more contiguous dermatomes, usually 1. Right? Maybe 2, but usually 1 dermatome. Now, you should know what is dermatome. Dermatome is an area of skin that is supplied by single spinal nerve. And the mucous membrane within the affected dermatomes are also involved. And on complicated cases, recovery is complete in 2 to 3 weeks in children and young adults and 3 to 4 weeks in older patients. Occasionally, the pain is not followed by the eruption. There can be pain, but there is no skin lesions. It is called zoster sign eruption. And in immunocompromised patients, there can be generalized eruptions. It is called disseminated zoster. Usually in herpes zoster virus, there is involvement of single dermatome or sometimes 2 dermatome. But in case of disseminated zoster, there are vesicles. More than 20 vesicles outside the involved dermatome. Then we can call it disseminated zoster infection. You can see there are grouped vesicles over a single dermatome. Now, herpes zoster ophthalmicus. If the trigeminal nerve is involved, there can be herpes zoster ophthalmicus, and the eye is affected in 2/3 of cases. Yeah? Especially when vesicles on the side of the nose are seen, it indicates the involvement of nasociliary nerve, which is called Hutchinson sign. Right? If the vesicle over the tip or side of the nose is there can be involvement of nasociliary nerve, which means there can be involvement of cornea, right? Which is called Hutchinson sign. And the ocular complications can be uveitis, keratitis, conjunctivitis, conjunctival edema, ocular muscle palsies, proptosis, retinovascular occlusion, ulcerations, scarring, and even necrosis of fluid. You can see this is the picture showing herpes zoster ophthalmicus. Okay. Trigeminal novis involved here. You can see there are a lot of crosses over the area. And in herpes zoster orticus, the facial nerve, which is mainly a motor nerve, it has a vestigial sensory fibers which supply the external ear, right? Including pinna and meatus and tonsillar fossa and adjacent soft palate. Okay. In Ramsay-Hunt syndrome, the classical sensory nerve zoster of this facial nerve are involved, which causes pain and vesicles in part or all that of distribution. Means pain and vesicles in external ear mainly, pinna and meatus, and can be in tonsillar fossa and adjacent soft palate also. If there is facial palsy with ear pain, with or without deafness, with ear pain or ear deafness, and vesicles over the external ear, it forms a classic triad: facial nerve palsy, ear pain, and vesicles over the external ear. Then it is called Ramsay-Hunt syndrome. Now, the post-herpetic neuralgia, it is the commonest sequelae of herpes zoster, and it is defined as persistent or recurrence of pain which persists for more than a month after the onset of zoster. There can be other complications also, like secondary bacterial infection, encephalitis, acute retinal necrosis syndrome, Guillain-Barré syndrome, transverse myelitis. Now, the treatment of herpes zoster is acyclovir 500 mg 5 times a day for 7 to 10 days. And if you remember the doses of acyclovir, 800 mg 5 times a day for 7 to 10 days. You can also give valacyclovir and famciclovir. In case of herpes zoster ophthalmicus and herpes zoster orticus, in herpes zoster ophthalmicus, there is risk of damage to the eye. In herpes zoster orticus, there is risk of facial nerve palsy. So in both of these cases, we give short course oral steroid along with the antiviral to reduce the side effects, to reduce keratitis in case of herpes zoster ophthalmicus, and to reduce the chances of facial nerve palsy in case of herpes zoster orticus. In case of post-herpetic neuralgia, we can give amitriptyline, gabapentin, pregabalin, topical capsaicin, and sometimes anticonvulsant like sodium valproate, carbamazepine, but these are not used so much these days because of the side effect, that chances of adverse drug reaction. Now, the molluscum contagiosum. It is caused by molluscum contagiosum virus. There are two main types: molluscum contagiosum virus type 1 and type 2. It mostly affects children. And most of the infections are caused by molluscum contagiosum virus type 1, that is 76 to 97% of the infection. And there is relatively higher incidence of molluscum contagiosum virus type 2 in adults and HIV infection compared to that in children. Infection mainly follows contact with infected person or contaminated objects, that is through fomites. Incubation period is usually 2 weeks to 6 months. And the lesion is shiny, pearly white, hemispherical, umbilicated papule, which may show a central core. We have already discussed what is umbilicated. It means the papule with central depression. We call it umbilicated. You should know the typical description of molluscum contagiosum. It is shiny, pearly white, hemispherical, umbilicated papule. And it enlarges slowly, sometimes may reach diameter of 5 to 10 mm in 6 to 12 weeks. Sometimes it forms a plaques composed of many small lesions. Right? It is called adminate or giant molluscum contagiosum. Most of the cases are self-limiting. It's resolved on themselves in 6 to 9 months. But sometimes the patchy eczema develop around one or more of the lesions, which is called infective eczema. You can see the typical lesion of monostotic contagion. Coily white, dome-shaped, central umbilicated papule. Now the treatment, we can either do surgical removal like curettage scooping cryotherapy, or we can give topical application of agents like trichloroacetic acid, phenol, topical salicylic acid, tretinoin, adapalene, and potassium hydroxide solution. And the antiviral agent, pseudofluid, can also be used. And if it is associated dry skin or eczema, it should be treated with emollients and possibly or topical steroid. Now warts. Warts are caused by human papilloma virus. Lungs. Warts are caused by human papilloma virus, and the human papilloma virus infect any site in stratum squamous epithelium, either keratinized skin or non-keratinized skin. It is mainly seen in infancy and early childhood. It can peak in adolescent and early adulthood. The incubation period varies from few weeks to more than a year, and the mode of transmission is by direct spread or indirect contact. Now the common warts, which are also called Verruca vulgaris, are mainly due to human papilloma virus 2, but mainly caused due to types 27, 57, 1, and 4. There are formed papules with raw furry surface, and they range in size from 1 mm to over 1 centimeter. And they are most commonly situated on the backs of the hands, fingers, it may occur anywhere. And in case of warts, there occurs a phenomenon called pseudocombner phenomenon, which means the appearance of warts over the scratched site due to autoinoculation of virus. It is called pseudocombner phenomenon. And the warts are usually symptomless. There are no symptoms. These are the pictures of warts you have seen. It's common. And the term periungual warts is applied if there are warts around the nail plate. Mainly nail biting increases the risk of periungual warts. This is the picture of periungual warts. Around the nail plate there is infection. And plantar warts is also called Verruca plantaris. It's most commonly caused by human papilloma virus 1, 2, 4, 27, and 57. And at first, there is a small shiny sago grain-like papule, which develops into sharply defined rounded lesion with a rough keratotic surface, and it is surrounded by smooth color of thickened horn. These plantar warts are mostly seen beneath the pressure points. And if there are closely grouped multiple warts, it is called mosaic warts. In this picture, you can see mosaic wart. Now the plain warts of Verruca plana, it mainly caused by human papilloma virus 3 and 10. These are smooth, flat, or slightly elevated and are usually skin colored or grayish yellow, but may be pigmented. And size varies from 1 to 5 mm in diameter. Face and the back of the hands are the most common site of Verruca plana. This is the picture showing Verruca plana, and this is the pseudocombner phenomenon. Linear development of lesion over the scratch site. Filiform and digitate warts mainly occur over the face. There are digits-like projections. Right? These are called filiform warts. Anogenital warts. It's mainly caused by human papilloma virus 6. Okay? 75% of the anogenital warts are caused by human papillomavirus 6, and remainder is caused by human papillomavirus 11. The typical anogenital wart is soft, pink, elongated, and sometimes filiform or pedunculated. The most common sites are the frenulum, corona, and glans in main and posterior fossa in women. These are the anogenital warts. Anogenital warts are also called condyloma acuminata. Now the treatment of anogenital warts. This is the treatment of wart as a whole, not anogenital warts. Topical agents like salicylic acid can be given. Salicylic acid has got a keratolytic effect. It helps to reduce the thickness of warts. And in case of anogenital wart, we can give podophylline and podophylotoxin. These are the antimitotics agents, and it should not be given in pregnancy. It is strictly contraindicated in pregnancy. This podophylline and podophylotoxin. We can also give topical 5-fluorouracil. Topical agents like monofluoroacetic acid, trifluoroacetic acid, silver nitrate can also be given, applied. Phenol can also be applied, and retinoic acid can also be applied over Lyrica plana. And in the surgical methods, we can do electrocauterization, cryotherapy, and CO2 geyser to remove the warts. Okay, thank you.